Hi, I'm Dr. John Martin with IV Family Health Updates. I'm here today with my sister, Dr. Catherine Martin, my brother, Dr. Edward Martin, and our special guest today is Dr. Jackie Tudeman. Dr. Tudeman is full-time faculty at the University of Miami. She is on the anesthesia staff where she specializes in both pediatric and ophthalmic anesthesia. And she's going to tell us a little bit right now about local sedation anesthesia, because that is certainly what a lot of people are having now, both for surgeries, colonoscopies, and I think there's a lot of confusion with people about what's local sedation, what's a general anesthetic, what's the safest way to do things now. And we certainly have a lot of new medicines that we're using, so it's
Yes, we do. Well, let's start with a local anesthesia, which is what we've been using for a long time. It can be used topically as a cream, or it can be injected in the tissues under the skin and within the vein to numb a certain part of the body, depending on the extent of numbness that you need to achieve and the depthness of that anesthetic that you would need for the procedure. If you accompany the local anesthetic with sedation, which is given either through orally, they're taking something PO,
like a Valium,
like a Valium,
okay.
or like a Valium or a hypnotic pill. Maybe 40 minutes before the procedure. Of course, you wouldn't be taking this and driving into your procedure. You would take it once you're there. It would give you a sense of relaxation and somnolence to a certain point where you would be much more cooperative with the procedure. Nowadays, though, in many of the offices and clinics that are well prepared to handle IV sedation, an intravenous line is begun, and we can administer intravenous sedatives that work the same family as the Valium, but of course the effect is much quicker when given intravenously, and the patient will immediately feel relaxed and not nervous and somnolent.
So it's great for those people that have a lot of anxiety about their procedure.
Absolutely. One of the things that's important to note is in the history, patients that already take benzodiazepines at home as a method of sleeping easily at night should disclose this, because that would mean that we would have to tailor the sedation a little more for them. So everyone's a different world. Everyone needs a different type of adjustments with the medicines, but they're very safe when given by an anesthesiologist or the surgeon that is very well familiar with the pharmacokinetics and pharmacodynamics of the benzodiazepines. And we normally accompany this with narcotics. If the procedure were to be a bit more painful, that a local anesthetic would not cover everything. We give them a little narcotic, and the narcotic will give you the proper euphoria and pain relief during the procedure. Our narcotics nowadays, especially the intravenous ones we use, have a shorter life in the system, so that we can, used properly, we can actually measure the time that we can begin it and turn it off so that the patient wakes up comfortably. Of course, there's some side effects to using benzodiazepines and narcotics, but we also can pre-treat the patients with something if they are sensitive to side effects, especially nausea, which is more common. But nothing that would preclude you from using these combinations of drugs to give you the right sedative environment for your procedure.
Because there's definitely some new medicines for nausea that even a few years ago we didn't have, that work much more effectively now.
Correct. Through advanced studies and scientific research, they've found specific receptors where our drugs now target those receptors to avoid the postoperative nausea and vomiting feeling that is normally elicited using, especially the narcotics.
Right.
And so we can pre-treat also using these medicines. They work very well, and we can actually start with one medicine that hits a target, and if that does not work, we can use another medicine that hits the same target but in a subspecialized receptor that would really, a receptor that is much more specific to the, what would we call it, the nausea and vomiting trigger.
Right.
Yeah, trigger point.
And then propofol, I know the Diprovan that we use now, is that still part of your local sedation, or is that the next level up in terms of anesthesia?
No, well, it depends. Propofol, which is a milky-like substance that is
Right.
used, diprovan, is a hypnotic. Okay, so it's not the family, it's not the benzodiazepine families, it's not narcotic, it's a hypnotic. Being a hypnotic means that it can provoke a state of much more a deep sedation, almost unconscious state, which would really more borderline in general anesthesia. The patient can keep breathing, but you really need to be a lot more vigilant. Before we hit that stage, though, there is a proper dosage where this propofol is infused so that the patient can respond to your questions when asked. And if you don't ask the patient questions, he'll close his eyes and just keep either falling asleep or just be very comfortable.
Right.
This is the level that we like the patients to be most of the times when IV sedation is given to accompany local anesthesia.
And when I know a lot of times we'll put people on the propofol drip, so you keep them at that level, and when you turn it off, they'll wake up fairly quickly, right? It has a pretty quick half-life.
Yes, and what we use to measure that, it's actually the term is half-life, context-sensitive half-life. For any medicine or drug that is given through infusion, you develop a steady state in the system. But as it gets taken up, metabolized, redistributed, there's a certain time level where if you turn off the infusion, some drugs will take a longer time to come down from wherever they have been redistributed in the body, and others will just leave off faster. Propofol will have its half-life context-sensitive time between 10-15 minutes, depending on how long you've given it and how long it's saturating with other tissues. We have also narcotics that are given the same way, some that will take 4 hours to go down to less than half-life, or some that will just turn off in 4 minutes. So for propofol, we normally leave them in a state where they can respond to us if we ask them questions, and then just go to sleep if we're not asking them questions, so the procedure can continue. Once you turn off the infusion, they should be able to wake up in around several minutes to 5 minutes and feel okay. The other good thing about propofol is that when given as an infusion, it has an antiemetic effect after you've given it for a certain amount of time, so that they don't wake up with that nausea and vomiting feeling, that nauseous feeling that most people get when receiving intravenous anesthetics.
And I think one thing we all think is that IV sedation is a safer alternative. But with any of these, you really, if you give enough, they'll stop breathing, right?
There's always a toxic dose. There's always a toxic dose for anything you give, any kind of medicine you give. And when you start administering dosages that are beyond the standard of care, or beyond what has been tested for you to get the effect that you're trying to get, then you're actually going into this effect where you have to be ready to rescue the patient. Yes, most of these drugs will probably have the patient stop breathing because it depresses the respiratory system. And at depressing the respiratory system, the patient will just not be willing to breathe. I mean, this is why wherever we do give intravenous any type of anesthetic, we have to have our rescue apparatuses and medicines available to help the patient breathe. Now, saying this though is if you are vigilant, all you have to do is help the patient just recover from that. It'll take several minutes to recover, and help them, give them a couple of breaths until they just wake up. It's lacking that vigilance in recognizing when the patient is actually beginning to decrease their respiratory rate, that you may get into trouble. So yeah.
Well, you work in pediatrics. Are there any special considerations in kids when compared to adults?
Yes. Children do not do too well with IV sedation. We do give it. And now, of course, it's double vigilance because they're smaller, and the dosages can be a little different depending on their medical history or what other accompanying treatments they're on. They need to be put asleep first before putting the intravenous line in. So how do you, because they actually get a general anesthetic in order sometimes to get the intravenous line in. But we do get children who already have their intravenous lines in, and we can give intravenous sedation, but it's a little different. It's a lot more complicated than just giving an adult sedation. So yes, it is special.
And general versus IV sedation, any difference?
No. See, it was thought that general anesthesia is riskier, but actually both have its risks. Both need to be approached in the same very specialized manner, and we have to be prepared for everything in both situations, general or IV sedation. If you give too much IV sedation, the patient will stop breathing. if you're not vigilant with the general anesthetic and you over intoxicate the body with gases or anything else to create the balanced anesthetic approach you're doing, you could also intoxicate the system, but now the patient won't tell you anything because he's asleep.
Right.
You know, we're looking at other signs and symptoms to tell us, oh my God. So yes, I mean, it's equal. It's safe. But both are safe under the right hands, under the right professional.
Well, great.
Okay.
Well, thank you very, Jackie. Thank you very much.
Thank
Thank
you for
you.
having me.